and pharmaceutical epidemiologist, known for his expertise in global public health and dedication to vulnerable and marginalized patient populations. He is the founder and CEO of Holding Fitzgerald, and he leads a global public health practice that specializes in health system reforms and capacity building with a focus on pharmaceutical and pharmacy management. Dr. Ryan's innovative anchor strategy approach addresses complex health challenges and cultivates sustainable change in local communities. His extensive research and fieldwork have earned him recognition as a leading expert in infectious diseases and pharmaceutical epidemiology, allowing him to develop evidence-based interventions that have a lasting impact on public health. Through collaboration with governmental agencies, international organizations, and local communities, Dr. Ryan actively implements effective public health policies and strategies, empowering communities to take charge of their health outcomes and reject the power imbalances that contribute to the continuation of neo-colonial dynamics. Dr. Ryan Paul holds board certifications in epidemiology, public health, and infection control. He has a Master of Science in Global Health and a Doctor of Philosophy in Epidemiology from Northwestern University. So right now, this is a great person we have in our midst, and it will really be a wonderful time with him tonight. So we give the opportunity for Dr. Ryan now to come and make his presentation. Dr. Ryan, sir, we welcome you.
Yes, thank you so much for your time. Can you put my presentation up on the stage, please? Do you want me to put my presentation up on the stage, or do you have it, Abdallah?
It is.
Thank you so much. Can I say something? Thank you for giving that prayer. I appreciate it. Do you mind if I say something?
Go
Abdul,
ahead. It's your turn. Go ahead.
And Dr. Obajo, I'm going to talk to our host, and I will give comments to everyone that's on today. And Abdul, if I refer to you, if you could please respond, would that be okay?
That's
I'm going to ask permission from you if I say something. Is that okay?
That's all right. Go ahead.
All right. So we serve a good God that gives good gifts. He is faithful and just to forgive us of everything, to purify us, to give us this opportunity. You are pharmacists. You are healers. I live in a world as an infectious disease and pharmaceutical epidemiologist where my grandfather said that pharmacists will always be the healers. No matter what they do, they will be the healers. It doesn't matter if a doctor shows up. It will always be the pharmacist that gives them the medicine that they need to be able to heal. And it will always be the pharmacist's responsibility to go out into the field and be able to do the work that we are called to do, to be able to fix the problems that we see within the world in which we live. And I would ask you this today: why do we have antimicrobial resistance? Why do we have this disease? Why does our antibiotics resist bacteria and find ourselves in a place where it simply doesn't work? And then I would hold ourselves and find ourselves in a place where we need to think about what that looks like. And what it looks like is that the entire movement of Holden Fitzgerald and everything that we do is under the idea that if I don't do something, no one will. And if you don't do something, no one will. So we get into the science and we move away from the politics. But I want you to think in the back of your mind, what does it look like when we have a sovereign system? A system that allows us to operate with no outside consequences. That we can serve our people no matter where we're at in the world without a bunch of externalities. What would it look like if I didn't need a grant as a public health professional? What would it look like if I didn't need to work for an international NGO that was going to give money to my country under the premise that if I do, then they would gain national security? We need to, as pharmacists, as epidemiologists, as infectious disease practitioners, to ask that question of ourselves. And with that said, I will happily go through the building blocks of an effective antimicrobial resistance stewardship program. Is that okay, Abdul?
That is okay.
So I was wondering about what I would say about all of this, because normally I was telling Abdul, I was saying I literally travel between Vietnam, East African time, West African time, Eastern Standard Time, Pacific Standard Time. And I find myself in this place where I'm, as you can see, in a hotel. And so I find myself in this idea that what's more important than an AMR, and I would hope that I will get through this really quick so that we can have a conversation about it, because that's really more important. It looks like there's probably, Abdul, I don't know, there's 93 people on. What's more important than a framework for antimicrobial resistance is the fact that all of you on this in this conversation understand what antimicrobial resistance looks like, and most of you understand what a general framework for being a steward of antimicrobial resistance looks like. So when we look at antimicrobial resistance, it's emerged as a global health concern, challenging the effectiveness of availability of antimicrobial agents and jeopardizing public health. I think that we can all 100% agree with that. In response to this growing threat, an effective antimicrobial resistance stewardship program is essential. Right? So what are we going to do? Such a program involves implementing systematic strategies and interventions to optimize antimicrobial resistance, minimizing resistance development and preserving the effectiveness of availability of antimicrobial agents. This opportunity really is about exploring the components of comprehensive framework for an effective AMR stewardship program, subjected to citations and studies that address the significance of global health issues. So the weird part about this conversation, guys, is that you already know the issue. So the question is how do we attack and how do we make change to all of these issues in and of themselves? Well, first, it's about leadership and governance. It's funny. Abdul is clearly a master at PowerPoint. But the first component of an effective AMR stewardship program is establishing a strong leadership and governance structure. The engagement of a multidisciplinary team comprised of health professionals is a crucial and conducted important component of leadership and governance. So we look at this study that Spellberg et al. 2016 emphasized the importance of involving experts such as pharmacists, which we're talking about today, infectious disease specialists, microbiologists, epidemiologists in the leadership and overall oversight as it relates to antimicrobial stewardship programming. Really, what we need to look about is globally and in country, an idea that we need to take control of developing policies, guidelines, and protocols that support effective antimicrobial use and ultimately resistance containment, which is certainly vital. These guidelines are going to ensure that healthcare professionals adhere to evidence-based practices when prescribing antimicrobials. Regular meetings should be conducted. We should have a conversation. We should be able to be open to the idea that discussion is necessary about antimicrobial prescribing practices, identifying areas of improvement, monitorization, program outcomes. So really what we need to think about is, how do we engage and foster collective decision-making? How do we enhance accountability and how do we improve overall effectiveness of antimicrobial stewardship efforts? So if we take that next step of education and awareness, the question then becomes education and awareness as a significant role of appropriate antimicrobial prescribing practices. What does that really look like? Regular education sessions for healthcare professionals. I think that a conversation as it relates to where we're at today. Like, why are we having this conversation? What is the particular issue about AMR? These sessions should 100% focus on appropriate antimicrobial resistance, duration, dosing, and de-escalation strategy. So when you talk about de-escalation strategies, you are opening up a can of worms, right? Because I think that everyone on this call can 100% believe or agree with the fact that we are doing exactly what we need to do to be a steward of AMR. So why then do we see a propensity for a problem? And what I would suggest to the entire group is that the way in which these programs are being funded, the way in which these programs are being propped up in any particular country, whether it's the majority world, the LMIC, whether it might be the global South, it doesn't matter what you want to call it. There is an unfortunate situation where the organizations that are funding the opportunity don't necessarily own and understand the opportunity in which the problem exists. So studies have shown that providing resources such as clinical guidelines, treatment algorithms, and educational material can significantly improve antimicrobial prescribing practices. Honestly, these resources serve as a valuable tool, right, for promoting evidence-based practice among healthcare professionals. So we have to like find a place of understanding, right? So what happens is we find ourselves in this place where somebody is funding the opportunity and we're taking care of patients, and we actually lose ourselves in the actual science. Like what we do is that somebody, so I'm not going to say words, but you can name them. Let's just take the top 5 international organizations in foreign aid that actually fund these types of programs. What happens is that educational initiatives need to be understood, which means that we need to understand that they need to be not limited to healthcare professionals alone. Like we need to engage community outreach programs to understand it and help them be aware of the importance of responsible antimicrobial use among patients, right? Caregivers, public is equally essential. So we look at studies that show this. Public education campaigns positively influence patient behavior and reduce antimicrobial resistance. So let's talk a little bit about antimicrobial stewardship activities, which it took me a while to get to, but Abdullah's got there for me. The implementation of various antimicrobial stewardship interventions is a critical component of an effective AMR stewardship program. So some good examples are interventions that include prospective audit and feedback, pre-authorization, formulary restriction, and applying these strategies really to healthcare professionals that can ensure appropriate antimicrobial prescriber inpatient and outpatient settings. So if we're leveraging electronic health records and a clinical decision-making support systems approach, where we're finding ourselves finding a vital aspect of antimicrobial stewardship, these tools actually improve prescription practices by facilitating easy access to guidelines and really prescribing real-time feedback to healthcare professionals. So if we look at this in of itself, monitoring antimicrobial use patterns, resistance rates, and clinical outcomes is it's actually a pretty crucial evaluation of the impact of stewardship interventions. I don't think that a data-driven approach does anything other than allow healthcare facilities to develop targeted strategies to contribute and combat antimicrobial resistance. But the question is, do they want to? Is it part of their strategy? And how do we assume that they're going to allow this to happen? Let's talk a little bit about surveillance and reporting, because I mean, I think that this is kind of one of the biggest things. So establishing a robust surveillance system is really kind of essential to monitor antimicrobial resistance in healthcare facilities and the community. This system enables timely identification of resistance, trends, and guidelines to appropriate antimicrobial prescribing. I'm hearing a lot of bangs, and I'm trying to get through this in a timely manner. Let's just figure out what the bangs are looking like. Abdul,
Yes.
let's bring it back. Let's bring it back to the entire.
Unfortunately, our subscription for tonight cannot take above 100 participants, and so we are having pings of people requesting to expand it, but we do not have the capacity for now.
Okay. All right. So is everybody good? Does everybody understand what I'm saying? Am I completely lost? Am I shooting my, let's do this. Let's talk love, right? Because this is easy. I'm like, I can talk AMR all day long. That's fine. The bottom line is that I have 50 professionals that all they do is AMR. Like, they can come into a hospital or health system and fix this problem. But the bottom line is that we're talking about 93 pharmaceutical professionals, PharmDs, bee farms in Nigeria that want information about the reality about what their situation is. And I just want to be honest with them that when you look at the way in which your program is being funded, much of the issue that you're facing as it relates to surveillance and reporting is about them monetizing exactly what you're collecting. So do you hear me?
Yes,
I want
we
you
do.
to hear me, but before we go on, I want you to hear me. I want you to understand that the Europeans and the North Americans that are financing your programs are actually taking your data and they're selling it without your knowledge. They're profiting from it and they're not fixing your problem. Can somebody understand and hear that? Because that's the reality. And that's what I'm here for. I can give you AMR stewardship framework programs, but the bottom line is that somebody needs to stand up and fix the problem that is, I am taking money from somebody that's stealing from the data that I am giving them as a result of the work that I'm doing with my patients. And I need an amen to that. Otherwise, everything else I say is worthless. Because the reality is that this program includes guidelines and policies and surveillance and reporting and collaboration and communication and all of these things under the idea that a vital aspect of such a program is established to surveil systems to detect resistance patterns to the healthcare facility and community, allowing timely response and better prescribing practices. But at the end of the day, if we sit, I gotta say it, if we sit in the middle of it and we talk about the technicality of it, who's getting the data? Have we ever woke up one day and be like, we're taking care of our patients. I wonder who is actually taking that data. What is happening with that data? And I'm going to bring this up along the way, but it doesn't matter what I think, but I want you to ask the question. When we do all of this work, right? When we further enhance the surveillance and reporting components of AMR, and we help healthcare facilities utilize a data clearinghouse, right? Which, like, for us, we help organizations enhance by using a data clearinghouse that is built on blockchain technology, and the recording mechanism for AMR ensures integrity, immutability of that information. So what happens is that we actually end up being in a place where we reduce the risk of data manipulation and tampering. So the use of blockchain-based data clearinghouse also enables a real-time access to AMR for both local and national use. So when you're talking about fixing the AMR problem locally, you're also talking about fixing the AMR problem nationally. And this actually eliminates the delays in data sharing, which allow us in this blockchain strategy to actually benefit from preserving patient privacy and ultimately utilizing cryptographic techniques for data encryption and anonymization, right? So what we have the ability to do is actually collect all of this data and actually understand what's happening so we can communicate with all of the AMR focused pharmaceutical companies that are in partnership with all of these international funding agencies, actually what's happening, so that when we are taking money from these institutions, we're taking money under the premise that they're actually doing work that's taking care of our patients versus monopolizing the market and giving a market to folks that don't necessarily or culturally have a right to the market in which we're serving. So we find ourselves in this place of research and innovation where we need to address the evolving change of antimicrobial resistance. Healthcare facilities should 100% support research initiatives aimed at understanding resistance mechanisms, developing new diagnostic tools, and ultimately discovering novel antimicrobial agents. But here's the thing, robust research efforts are essential for informing and updating antimicrobial stewardship practices. So we have to take a step back again and say, oh, this is all great. I hope that this works out. But the bottom line is that if we're not regularly monitoring emerging resistant trends, then we're not doing the vital work. So we need to, in collaboration with research institutions and staying updated on the latest developments in antimicrobial resistance, really figure out what our stewardship and general strategies are going to allow us to exit so that we can have an unusual healthcare facility to adapt to the practices accordingly. So the most important thing for us is to understand that we need to implement a rapid diagnostic understanding of what is happening in hospital stays, what's happening with antibiotic costs, and what's improving patient outcomes. This is why, I mean, we spent like a year. Holden Fitzgerald has spent a year, not just in the African continent, but in Southeast Asia and the lower Antilles of the Caribbean, just asking questions. And what we found out is that the very things that we need to actually deliver care is not being delivered. What happens is that we say we need AMR solutions for stewardship. We need X, Y, and Z. We need hospital collaboration and communication. But really what happens is that an international organization gives money to our federal government. It never trickles down. We get upset about the fact that what we thought was going to be something that was going to improve our situation doesn't improve our situation. And then we get upset about the fact that the very thing that we knew was going to happen actually happened. So when we talk about collaboration and communication, I sometimes wonder, guys, what that looks like, right? So there's 93 people on this call. Everybody knows that I'm a white guy from North America. And you're asking me to talk about AMR, stewardship, and that's great because I know a lot about it. But what I know a lot about is not necessarily what should and should not be. What I understand is that if we are going to find a place where we look at our drug supply chain, if we look at how we overcome antibiotic trafficking, we have to look within our communities to decide what is okay and what is not okay. And what I would suggest to you as a group is maybe the way in which we are funding these types of programs is generally not okay. Maybe in and of itself, we are allowing external organizations to monopolize our data, monetize our data, and we are missing the opportunity to be able to serve patients in a new and fresh way. Now, I am not saying that equivocally. I'm not saying that as somebody that wants it to be an end all. But what I would suggest is when we look at collaboration and communication, and we look at surveillance and reporting, I have just in my notes 3,000 words. about research and innovation, about education and awareness. And what I would ask of these brilliant pharmacists, both clinical, both infectious disease, is how do we create a sovereign and sustainable system within country, whether it's Nigeria, whether it's Cameroon, Tanzania, it doesn't matter, whether it's India. Can we start to think about the beautiful things that we can extract from the rest of the world, take the good stuff and start to build a system around AMR and around supply chain that makes sense today for our cultures, for our people, that is irregardless of what the global system is expecting of us. And with that, I will pass.
Dr. Biajuru, can you hear the speaker?
I can't hear him. I think it should be from his hand. Dr. Ryan, are you still on?
Can you hear me?
Yes, we can hear you now.
My apologies, I lost you for a second. Is everybody okay? Has everybody survived my opinion? Is everybody okay? Nobody's gonna punch
Yes.
me in the face? Okay.
No, absolutely not.
Not at all.
I want, there's 99 people on this call. Here, let me turn my video on. Look at me. You are 100% responsible. You're brilliant, right? Hear me. You're pharmacists, you're infectious disease, and you're clinical. Nobody is ever going to say that you're not qualified. Nobody's going to say that you're not qualified. So at that point, like at the point that you understand that you're qualified, at the point that you understand that clinically you understand everything that I talked about, put it all aside. When we think about how all of these things are funded, just think about that. Like, can we collectively create something that is our own, that actually serves people? Like, can we take care of people without all of the other, I mean, think, I've been a part of it. I'm a global and public health practitioner. I'm an epidemiologist. I know all 50 organizations that have given $12 billion to the African continent. Like, I get it. But like, can we collectively do something locally that's our own? Like, that's taking care of people, that isn't those people's program. That's what I care about, because like when we talk about evaluation, like let's talk about evaluation and continuing quality improvement. Really what it is, it's you, right? Like I don't even want to go through the script, because at the end of the day, you understand it. You understand what regular assessment looks like. You understand what monitoring outcomes looks like. You understand providing feedback, right? Like if you had the data here all the time on a national and local level, what would you do with it? Well, you'd do a lot of things, but you have to remember that the data that's being collected in Nigeria is actually being put in a clearinghouse and being sold to European and North American entities. And guess what? All of the monetization of that data as it relates to AMR is not being paid back to your people and you to be able to make sure that you have a sustainable sovereign system, right? So it doesn't matter how awesome the framework is if we don't say, hey, we're going to create a system that allows us to provide for this. Then what we're doing is we're literally giving every beautiful part of our education, all of the work that we've done, we're giving it to guys that look like me, right? And that's what I want people to understand, right? And everything that I've said, it is my own opinion. It has nothing to do with the Clinical Pharmacists Association. It has nothing to do with the Infectious Disease Pharmacists Association. But what I can tell you is that Holden Fitzgerald has built some incredibly successful health systems that create a private system that fund not-for-profits and take care of people of need, and it works. And so whether it's understanding AMR and drug supply chain management and understanding stewardship. I mean, I just had a conversation with the government about antibiotics being trafficked, right, from one country to the next. And they wanted some complex system. When I told them, I said, hey guys, it's not about a complex system of stopping trafficking of black market antibiotics. It's literally about paying for antibiotics for people that are going into the black market to pay for it. So do we care about people over profits? Do we care about, in a system where we need to, it's pharmacists and epidemiologists, immunologists, microbiologists, virologists, infectious disease doctors, NPs, PAs, nurses. At what point do we take all of this knowledge in conclusion and say, effective antimicrobial resistance stewardship programs requires a comprehensive framework, addressing leadership and governance, education, awareness, AMR activities, surveillance, and committing to efforts to combat AMR and safeguard effectiveness of treatments? Let's be honest, we're already doing that. But what we're not doing is standing up to the people that we think are paying for it to our benefit. So how do we bring that into our community and create a circular economy that allows us to serve our own people, that allows us to do the work that we were called to do in a way that is righteous, is a way that whatever the universe or God would call us to, but ultimately, how do we find the space where the work that we're doing, we can separate the motive, profit, from the motive of healthcare? And that's all I ask. So with that, thank you so much for giving me your time. I certainly appreciate it. Thank you so much.
Thank you so much, Dr. Ryan, for that wonderful and eye-opening presentation. Thank you so much. I have learned a lot, and from a little bit of summary on your presentation, my major take-home today, aside from knowing that the antimicrobial stewardship requires serious leadership and governance, which would actually require a multidisciplinary team of pharmacists, infectious disease specialists, epidemiologists, and all that, a proper policy and guideline development, regular meetings to discuss prescribing practices, which would help improve our practices and outcome monitoring, and also collaboration between health facilities and other things. The major thing I have taken home today is that we should alongside thinking globally, we should try to get our data used at our local level. Rather than always allowing people to come take our data away, we can do things at our local level. Thank you very much for that. Not everybody would be able to, because you're from that side, not everybody will be able to, okay, openly tell people, okay, my people are probably using you. Like in Nigeria, I would say using your heads. So we will try to see how we can make use of the data we are collating here and actually get something out of it for our own people. Thank you very much, sir.
Dr. Abajura, that is,
Yes, sir.
thank you for highlighting that. I mean, I can talk about, I mean, everybody on this call understands AMR. What I would say is that Holden Fitzgerald understands that the data that you're collecting is being monetized without giving anything back to the community. And honestly, that upsets me. It makes me angry, right? Like, so I stand up and I want to fight a little bit. But the recognition is that we have a lot of people. And what would it look like if the data that everyone's collecting from patient populations and inventory produced money to take care of free healthcare? Because all of the organizations that you're working with right now, they're taking your data and they're not paying you for it. So I would hope that we can continue this conversation in a big way about, like, how do we figure out how to, in a not-for-profit way, bring that money back to your communities. That's all that we hope for.
Okay, thank you, sir. So we would work on it with CPAN and Infectious Disease Pharmacists Group. We'll definitely have more meetings and collaborations with you on how this can be done on a higher level within our own country and within our communities. So it's time for comments, for questions. Anyone who has any comments or any question or any contribution should please raise his or her hands up. I can see Dr. Joda's hand, Professor Joda's hand up already. So Prof. Ma, you can ask your question or make your contribution.
Thank you so very much. And thank you, Dr. Orion, for the eye-opening presentation. It's difficult. I can understand the point from which you're coming as being, should I say, on the other side of the divide. But for us, on this side of the divide, there are various issues that results in, you know, there's a saying that he who pays the piper dictates the tune. So if we, and we, I use we in the plural context of low and middle income countries, if we as a people, we are not able to get our acts together to be able to define exactly the best, to define the best terms we can get for the monies that is coming our way, then we're going to settle for whatever it is they are bringing, because we for whatever it is, we have not, we have the manpower, but we have not developed the capacity of our manpower to get this done ourselves in country. Number one, we have not developed that collaboration sufficiently for each of our healthcare professionals to recognize each other's competencies so that we can work in an effectual way to do this by ourselves. And so it becomes a big problem if we cannot achieve it ourselves and we are, as it were, sitting there and somebody says, hey, I have money for you to do the ABC. And you're like, oh, okay, we can do ABC then because of you have the money. And at the end of the day, they have brought the money. They are going to do with it as they have decided. I always give this example in class, and that is for the various, just as you said, for the various international agencies. You know, we have a program on AIDS, we have a program on TB, we have various programs. And of course, more recently, these various programs on antimicrobial stewardships are coming. And the programs come with the documents to be filled. They come with the personnel to fill it. They come with the machines and the equipment that will be used. So when the program ends, everything folds up into cartons, people pack their bags, and they leave with the data they have collected. Our governments have not thought it fit.
Do you want to, let me stop you. Do you want to be our CEO? Because I need to like clap for you and then let you finish, please.
Sorry, but I'm a lecturer, and I see this, you know, so they go with all the data, they go with the equipment, they go with the people, because the people were doing the work. Our own people here are just like the technicians, so to speak, the one feeding the data into the systems. And then when the program is gone, they're gone. And our government has not thought it fit that, oh, while this program is on, why we need to train X number of competencies to learn what is being done, to learn the rudiments of the instruments that is being used, to learn how to create the programs, the data files, the whatever, so that by the time the program finishes, there can be a semblance of continuation of that program. You know, so you have a free program today, and that program ends because the country, the NGO sponsoring it has left. And so the people that are dependent on that program are suddenly left high and dry. You know, so it's difficult to say we're going to fight back and get it when we don't have the systems in place to ensure that we even negotiate the best terms in the first instance. You know, so I just wanted to put that out there. Thank you.
Will you put on your videos so I can see your face? Because I want to respond, because it was really good, but I don't want to respond if I can't see your face.
Hi.
Yeah. Yeah, I mean, so that's a big question, right? Like you basically said, hey, that's a great idea, but like, how do we do it when these people are stomping us? That's what you said. You're like, hey, all of that's great. We know how to do it. But like, if the people that are funding it are basically telling us it's their way or the highway, how do we say no? So this is what I would say.
Do we even know to say no? That's the issue. Do we know to say no?
Yeah. Oh, okay, there you are. I'm sorry. I thought you were Tulope. My apologies. She is powerful. Like, honestly, Enoch, take note. Like, you need to know her name. Like, this girl, this woman is powerful because she is speaking truth. And this is really what it is. It's no different than the idea. Like, let me speak to it from this, right? Because I'm not going to speak to you from, because otherwise I'm just going to be talking bad about international NGOs. I don't want to do that, because there's a lot of brilliant people that work for, yeah, they're doing a lot of good, right? From Gavi to Global Fund to Gates. I mean, they're doing amazing things. I'm not saying that, but this is what I'm saying. Like, let me speak to you specifically in your community. If me, as a white man, right? Hear me. As a white man in my community decides that my white brothers and sisters are being exploited, what do? I fight them. I literally fight them, right? It's not about healthcare. Like, I'm a doctor, like I went to college, but it doesn't matter because I show up. But the reason why I show up different today is because I recognize is that my brothers and sisters were taught to do something very bad. And so I have to stand in the gap to say, Like, let's do it differently, right? Like, I'm a German Jew, right? So I understand what it looks like for my grandfather to have been gassed in a chamber. But the bottom line is that if I walk into a boardroom in America, I'm a rich white guy. I can get whatever I want most times. So this is about inequality. It's about equity. It's about disparity. It's not about skills and talents. It's not about any of those things. So what I would suggest as a pharmacist association, throw Ryan's opinion out and just see the facts. Like, is AMR working for us in our communities? And is the INGOs and the funds that we're getting from international and foreign aid working? And what you'll find out is that it's working until they leave, right? And so and so what happens is that all of our associate directors, managing directors in Africa, you know what they find out is that they don't need to be paid. They need an opportunity to be an entrepreneur, right? They don't need a job. They need to know we're there for them no matter what, through thick and thin, as we grow this opportunity to fix problems in Vietnam, in the Philippines, in the African continent, in the lower Antilles, in Brazil, in Peru, because the bottom line is that there is absolutely no reason for me to run a company fixing problems for rich white people in America and Europe, because there is no problem. There's no problem. There is absolutely no problem. They want to, there's no problem. So what happens is that when you look at my master's degree is literally my thesis was in universal healthcare. It's in universal healthcare, socialized systems, the beverage model, the Bismarckian model. And when you look at all of those systems and you bring them together, what you find out is the only thing that matters is not solidarity, because at the end of the day, I can be a liberal white man and be like, I'm sorry that colonization happened. It fixes nothing.
Yeah.
But if I step in and say sovereignty matters, now I go from solidarity, which doesn't mean shit, to sovereignty, which means everything. Because solidarity is prayers and thoughts. Sovereignty is we're going to actually give you unrestricted funds because we believe that who you are and our national security relies on your community and your culture and the way in which you take care of your people. But that's not what's happening, because guess what? 95% of what's going to go into African continent from international development organizations in the United States today is going to go to one management consulting firm that doesn't think that you have the ability to be able to create your own health systems. And so it doesn't matter about AMR. Like, that's what I want people to know. Like, you guys get that. So we need to then come in. And so you say, well, what's the solution? Well, the solution is I'll give you the money and I don't care about losing it because I happen to be a rich white guy that doesn't give a fuck. And I'll give you the money, you build the system, and then you do what you need to do, and then we'll support it. Period. Because I care more about supporting your system and your success than I care about making money. Because at the end of the day, my God told me that what matters is me doing what's right, not what's profitable.
Thank you. Excellent point. Dr. Aymer, over to you.
Dr. Ryan, are you still there? Okay. I don't know if he's done.
Yeah, it's done. Next
Okay,
person.
thank you.
No,
Thank you,
I'm here.
Doctor.
I just got
Okay,
fired up.
thank
So
you. Thank you.
I need to
So I don't
come
know,
off.
do you still have time to take more questions? We have a few more hands up and some comments to some questions in the comment section.
Let's talk until we can't talk anymore.
Okay. Thank you very much, sir. So I have a Fam Tolulokwe Ajayi's hands up. Fam Tolulokwe, can you give your comment or your question, please? Please unmute and ask your question. Fam Tolulokwe Ajayi, if you're still on this call. Okay, while we wait for her, if she's still there, I can see somebody is asking which of the AMS interventions is of the highest priority to implement first before the others. Pharmacy Sikiru is asking which of the AMS interventions is of the highest priority to implement first before the others.
Easy. That's easy. Leadership and governance. You have to just, like, as a collective, right? This is the cool part about talking to an association. You guys get to decide. So it's about leadership and governance. So you guys collectively talk about antibiotic resistance. I mean, think about it, guys. Like in North America and Europe, we don't think about Cipro, azithromycin. We don't think about penicillin, cephalosporin. So the question is why is it an issue in the rest of the world?
Okay,
right?
thank
No,
you,
I'm just
sir.
saying, like, why? I'm not going to answer that question, but what I would say is that leadership and governance is the most important, because your leadership and not your leadership and governance, but the leadership and governance in general have no clue. Like they don't know. They don't know what to my fault if I, but
all
like,
right.
They have no clue. Like they have no clue. Like, so at what point do we say, like, at what point do we say that the decision makers, right, the people that make the laws, that give that decide on the funding, let's take it back, because I know that I'm a big proponent of nothing in international funding, but let's just say that international funding 50% of the time makes sense. Let's just agree that that makes sense, no matter what, wherever it comes from.
Okay,
I would be interested in, yeah, no, so leadership and, sorry, but yeah, I mean, leadership and governance is the most important.
Okay, thank you very much, sir. So, Fam Tolulope Ajayi, you're on now.
All right. Thank you very much. Dr. Ryan, thank you so very much for this insightful and high-opening presentation. I just want to lend my voice to what you shared, that data is a big deal issue globally now. And it's high time we all also begin to take it very seriously, very, very seriously. We all know that leadership and governance is at different levels, and it's the big thing. Everything rises and falls on leadership. So thinking out of the box, I'm just trying to see how we already know what the problems are, but taking them headlong and seeing how the resources that follow data sourcing, data aggregation from our systems can also bring back those resources to develop and build our systems so that things continue to get better. So I'm just thinking that as CPAN, as the various bodies, pharmaceutical bodies, CPAN, at CPAN level, at ACPN level, at PSN level, is it possible we begin to engage in serious advocacy? Because it will also seem that the people at the topmost level of governance in the country don't really know about what we're talking about. We don't really know that we are wasting resources. We don't really know that we are not tapping into the wealth of potentials available to us. So we need, as CPAN, as ACPN, as PSN, all pharmaceutical bodies in the healthcare delivery system in the country, we need to begin very serious advocacy, especially when peanuts are dangled at individuals, all in the name of researches and, research works for data aggregation. Perhaps we can, maybe at the level of ethical approval and all that, we need to enshrine, make some provisions, put some provisions in place where we have, something to ensure that value comes back to the system. At that point where the research work is being initiated is when we're able to also negotiate the terms and conditions to ensure that when we are wrapping up, the funder of the project is not just going to pack it all up and then move. We should ensure value is retained in the system. I think that's where we're not doing so well. These things are done at pockets of individuals all over the place. We're not really taking it up at the level of our systems to ensure that we protect ourselves and then we get the best possible from all those research works that are carried out around us here. So I'm just lending my voice that we need to do more in the area of advocacy. Thank you.
So number one, everybody on this call, we are not a job center. We are 100%, we build practices we help build practices. Because the reality is what I found out is that everywhere we went in the world, they were so much smarter than me. So why would I employ them when I could contract them to build a business that we help own, that they own themselves? So I don't know who there you go. I need to see you. So this is my struggle. I wake up every morning and I'm tired. I'm tired of everybody. Let's see, 86. All right. Well, there's not that many people. There's not that many people that thought what we're saying is stupid. But let me talk to you from a heart thing, where I wake up in the morning. It's I'm sick most mornings. I feel I have a lot of money and I made a shit ton of money in the healthcare system. And my grandfather owned Rite Aid. Most of my life has been representative of this idea that healthcare is just basically a commodity that pays me to screw up in life. So at 42 years old, when I look at my life and I wonder what would be awesome, what would my son think, right? What would my son think, right? If I talked to Aji and I said, look, we're going to take all of your data and I can make $1.50 USD for every single prescription that's processed in your pharmacy, and I'm not going to give you any of it. And then you think that I'm literally taking that money to give to an international organization that's taking care of poor people. That is America. So I'm please know that. America is taking your information, they're stealing from you, and they are telling you that they're taking from poor people. They're taking from your poor people. They're not. I am a rich man because I used to do it. I'm telling you, like everything that we try to fix is a byproduct of how I got rich and how my family got rich. And I decided as a white man to decolonize healthcare by telling on myself, right? That's it. Like white people are taking from the African continent. Like I had a conversation 2 weeks ago. A telehealth company that is building their entire system on it makes me so angry that I can't even say it. Like their entire business model is based on the idea that kids dig for uranium in the DRC, and then they use that uranium to take care of patient-assisted systems that require that product within telehealth, and then they think that they're taking care of kids that are literally digging for uranium in DRC. So you have to understand, like, I don't care. Like, I'm rich. Like, I don't need money. I'm pissed that, like, because I'm an infectious disease and pharmaceutical epidemiologist. Most of our employees are pharmacists. They will help you. We'll fix the we'll fix the framework problem. We'll help you with the supply chain. But what we can't help you with is the fact that the international organizations that you think are actually funding your healthcare are actually hiring people that are actually putting children into slave labor in places in Central Africa. And you know what they do? They just look away. Doesn't matter if it's closed, doesn't matter if it's uranium, it doesn't matter if it's silver, doesn't matter what it is. And so at what point doctors and people like me literally say, like, can we just talk to the Clinical Pharmacists Association in Nigeria or infectious? And you guys can never invite me back. It wouldn't matter. You will never forget me. Because the bottom line is everything I'm saying is true. Like, you know it. Like, there's nothing that I'm saying that's a lie. Like, you literally have American you're hiring telehealth companies that are hiring your children to put their hands in the fucking. So I just decided that my rich people that I'm from don't get to participate anymore, right? So when I talk to Ajayi, I say, Enoch, let's hire him and let's find out a way to give him the tools to absolutely dismantle the system that's actually ruining not just the African continent, but everywhere, right? Let's decolonize health. Like, let's make health about people, not about white people's profits, right? So anyways, again, I'm going to super get in trouble for what I said, and I apologize, but I mean, it is what it is. And this is what we're doing. So.
Thank you.
Thank you very much, Dr. Ryan. Thank you. They say the truth is bitter, but we have to swallow it. Okay. I call on the next person, Igwe. If you're here, you can unmute and either ask your question or make your contribution.
Okay, Dr. Ryan, thank you for your presentation. It was quite motivating. So, but in the spirit of this motivation, if we want to now begin to practice, because what I'm taking out from here is, while we are thinking global, we should act locally to make our impact felt. So when we want to act locally, because you have said that where you are from, like in North America, you are no longer discussing things like cephalosporins and penicillins, and you are wondering why. So I am sure it's because you people have taken time to look at the problems and build a framework on how to, go about solving those problems. So I would like you to be more practical, to tell us what and what, as in how did you start? How do we start? With more practical suggestions on how we can start, especially fostering cooperation and coordination among the different healthcare professionals. Because here in Nigeria, every clinician is trying to claim supremacy over the other. So I don't know how, if you can throw more light on that, like fostering cooperation, what are the steps that you people took over there in North America? What are the frameworks that were available for you to have been able to achieve this, so that even if we cannot copy everything, but we can at least adapt some of it to our local situation?
Can I see your face so I can just for a second? It's fine. I just want to respect you when I answer. You go ahead. It's okay. Love. So I'll answer. So here's how I think. Number one, you own locally. So group purchasing organizations for drug supply chain, durable medical equipment. You build private pharmacy chains outside of the international organizations that own your hospitals and health systems, and then you allow for a general movement to supply beyond that control. So that's number one. You, Igwe, and all of your people, you say, look, we have X, Y, and Z. We have these patients. We have this population. We're going to buy by ourselves. And so, like, the way in which we have built our model is that if you want to buy by yourselves, then we will buy by yourselves, and that's it. So number one is to own your market, right? It's not a matter of, it's not even really a matter of capitalism. It's not even a matter of socialism. It's the idea that the people that you work with, you understand what their tolerance is for loss and gain, right? So then you have to have an organization that's willing to honestly lose money to build that market for you. So that's why I built Holden Fitzgerald, was this idea that we could show up in any global South continent and we'll just lose money. And then people say, well, why would you want to do that as a businessman? And I tell people that if we can create sustainable systems where everyone is buying in bulk together, then the bottom line is that 10 to 15 years later, we will win, right? We will make up our game. Right. So what happens is that I literally am showing up in the world saying I'm willing to lose money for the next 10 to 15 years, which means that 42 and Enoch's over here saying, holy shit. But here's the thing, like, we're willing to set up a private pharmacy network and a group purchasing organization. And if you bring enough pharmacists together, what we can do is actually create like a Vizient or a Premier, or like we can create like a huge national private GPO that is owned by pharmacists, right? So all of the mechanism for taking care of these people within pharmaceutical care is owned by pharmacists, and we simply set it up and we license it to you guys, and you basically do it. And we take the McKessons, the Cardinal Health, the AmerisourceBergens, and all 100 people around the world from Ireland to New Zealand, we create the supplies. So where there is, like, we were just having a conversation with my good, Varicella. So you guys know Gabriel. You guys know Gabriel because he's basically a model. He's like a very handsome man. But like varicella as a vaccine is a shortage in Nigeria. So we come in and we say, well, we'll fulfill that. We're not going to manage it. We don't want to own the market, but we'll help fulfill the need for Viscera vaccinations. So we need pharmacists and frontline workers to help us develop the business model. And the cool part is that since we don't really care about owning the business model, we just help healthcare people that are entrepreneurs build it, and then we support it. So it's like, I don't want to say it's like McDonald's, but it's kind of like if McDonald's had a bunch of money to take care of people that couldn't gain access to prescriptions and vaccinations, that's who we are. And the fact that I hate government.
Dr. Ryan.
Am I in trouble? Did I just get kicked out of the
Okay.
association?
Dr. Biagiro, I think you can
You're back now.
start wrapping up.
Okay.
Am
Thank you
I in
so much,
trouble?
Doctor.
Did I get kicked out of the association? I'm sorry.
No, no, you're still on, sir. You're still on, sir. Sir, are you done? Are you done? Do you still have anything to say?
I mean, no, not about that situation. I mean, I can talk forever. I mean, like, so here's the deal. I have 5 things that I'm angry about. 5. And those 5 things kill old people, kill babies, kill poor people, kill middle-class people, and keep rich people rich. So I have 5 things that I always talk about. So there is always that. And I want this association to understand it, not because like I want like a political thing. It doesn't have nothing to do with that. It's really about clinical stuff. Like when you guys wake up tomorrow morning, you have 50, 100 people that you got to take care of. So you have to ask the question, who's paying for that? And what you'll find out is that 50% of the time, it's white people that don't give a shit about you. I'm just telling you. So like, can we just have that conversation? Like across Nigeria, in Tanzania, and I'm willing to go broke over the fact that European and North America and international aid is literally using the African continent to create national security that doesn't exist. And if you actually are honest with yourself, you will wake up in the morning and you will realize that guys like Dr. Ryan, they're not jerks. They literally are sitting on the other side of, and we're looking at it and saying, like, we're getting rich. We're getting rich in the African continent while people get poor and have no health care. So the question is, why? Why can I get rich in the African continent while you can't take care of your patient? That's all I want you to ask. And Ubaja, I told Gabriel, I told you guys that, like, let's do it. Let's build, and here's my commitment I will commit $100,000 USD to the African continent for the clinical association to build a system that prevents antimicrobial resistance in the patient populations that they're serving. So you guys figure that out, and I will 100% give it to you. No problem. But here's the thing. after we actually take care of people that need something, let's figure out how to take care of our communities without people that don't give a crap about us.
Okay, thank you so much, Dr. Ryan. Thank you so much for answering this call to give us this presentation today. Thank you for such an insightful and a wonderful time this evening. We need to round up now. In the absence of any more comments and questions, time is far gone. We need to round up. So I call on the national chairman for closing remarks. I don't know if Dr. Mado is still on this call. I can't see him on the call. He's no longer. Okay, yes, I can see Dr. Maureen Wafo. I call on the vice chairman, national vice chairman of STPAN, Dr. Maureen Wafo, to give us the closing remarks. Dr. Maureen.
Good evening, everyone.
Good evening, ma'am.
Quite an educative presentation tonight. Wow. On behalf of our national chairman, Dr. Joseph Madu, I want to appreciate you, our presenter. Wow, you did so much for us this night. Thank you so much for finding out time to speak to us this night, despite your busy schedules over there. We appreciate you, sir. God bless you. Also want to appreciate our dear moderator. Wow, my dear, you did so well. Thank you so much. Especially, I want to congratulate our specialty group, infectious disease group, for tonight's presentation. You are always setting the pace for others to follow. Thank you, the able coordinator, Dr. Issa. Thank you so much for your wonderful work you're doing for us in SIPAN. We appreciate. I want also to thank everyone that participated in tonight's presentation. Thank you. We are up to 90-something at a point, and I was not surprised. I want us to go back to our various institutions and continue to practice what we've learned tonight. With God, it is possible, despite the challenges we have in our various institutions. Once again, thank you so much, sir. And we would love to see you again, speak to us soonest. God bless you. Thank you.
Thank you, Dr. Maureen Wafo. We call on Dr. Issa, the Dex Officer 1 for Infectious Disease Pharmacies Group, for his vote of thanks.
All right. Greetings, everyone. Good day, those in Nigeria and the rest of the world. We really appreciate the presence of everyone at tonight's meeting. And it's supposed to be a wake-up call to all of us that it is time for action. Beyond the meeting, we should have implementable solutions to all our problems. And we do hope that the talk tonight with Dr. Ryan is an eye-opener for all of us to go into the field and bring up something that can be of benefit to our society. We can't thank Dr. Ryan enough for accepting to be our presenter, despite a notice of less than 5 days for him to come on board this meeting. Dr. Ryan, you are wonderful. I appreciate, I can see Enoch Kimmel, FAMD is online too. Enoch, thank you from Israel. I can see Gabriel also. We also thank you. Our elders in the profession are many online, and I really appreciate them. But please permit me to mention our general in our midst, Air Commodore David Babalola. Thank you so much for coming here tonight, and we can see they are supported by a lot of people. I can see at least 2 group captains. I can see squadron leaders. I can see flying officers. I can see professors and other people in our midst. Thank you for honoring us, and we do hope that when next we call you all for special meetings like this, you honor us with your presence and also make the meeting a very lively and educative one. Thank you so much, everyone.
Thank you so much, Dr. Issa, Dex Officer 1 for Infectious Disease Pharmacies Group. We've come to the end of this meeting, and I thank everyone for participating. Without you, this meeting wouldn't have been a success. So we now call on pharmacist Amin Kamil. Pharmacist Amin Kamil, if you can lead us in the closing prayer.
Okay,
Or has he
before the
left?
closing
He was
prayer,
here just now.
may I please remind us all that Dr. Ryan has given us a challenge. Bring up a proposal that's implementable. Bring us a proposal that can solve real problems about antimicrobial stewardship, and you can count on his support at any point to make it come to existence. Let us go into the drawing board at the moment. The Clinical Pharmacists Association of Nigeria is hereby challenged to go into the kitchen and bring up a very good proposal. And Holden Frederick will be very, very happy to collaborate with us at all points. So I want to note that and remind us all there's a challenge that we should all take from here on.
Okay, thank you very much, Dr. Issa, for that reminder. It seems like pharmacist Amin Kamil is no longer here. Dr. Bello, please, can you help us with the closing prayer? Dr. Bello. Dr. Bello online?
I think you just call any volunteer to go ahead.
Okay, please, any volunteer can help us with the closing prayer since most people have gone offline.
I'll close you with a Christian and a Jewish prayer.
Please go ahead.
Okay. All praises and adoration to Almighty God for the opportunity we have with our beautiful presenters and well-packaged work. We pray that we should be able to contribute positively regarding stewardship in antimicrobial. God bless us all. Have a wonderful time. Bye.
Thank you. Amen. Thank you. So good night, everybody. We've come to the end of this meeting.
Thank you so much,
Have a
Dr.
good night
Ryan.
rest, everyone.
I believe
Thank you very much,
the
Dr. Ryan.
End of nice meeting you and seeing you again tonight.
I want to talk to you.
All right.
Thank you so much, Dr. Ryan. Really enjoyed your
Thank you.
presentation. Bye, everybody.